Welcome to NCLEX Map. Today we are diving into one of the most time-sensitive, life-threatening emergencies in all of critical care, hypovolemic shock. This is the shock state where the body loses so much circulating volume, whether blood, plasma, or extracellular fluid, that it can no longer sustain adequate preload, cardiac output, or tissue oxygen delivery. The result is a cascade of compensatory mechanisms that eventually fail, leading to organ failure and death if not reversed quickly. Every nurse must master this. Hypovolemic shock begins with loss of volume. This may be hemorrhagic, such as trauma, postpartum hemorrhage, GI bleeding, or ruptured aneurysm. Or it may be non-hemorrhagic, such as severe dehydration, burns, DKA osmotic diuresis, or massive third spacing from pancreatitis or peritonitis. The core issue is the same: too little circulating volume to maintain perfusion. When volume drops, preload collapses, stroke volume falls, and cardiac output plummets. The body immediately activates the sympathetic nervous system, trying to preserve perfusion to the heart and brain. You will see tachycardia, narrow pulse pressure, cool clammy skin, delayed capillary refill, and increasing respiratory rate as early compensatory signs. But if the volume loss continues, blood pressure falls, mental status changes, urine output declines, and lactate rises, a sign that tissues have already shifted to anaerobic metabolism. Recognize that shock progresses in stages. Early shock may show normal blood pressure because the body is compensating. Decompensated shock reveals hypotension, confusion, and organ dysfunction. Irreversible shock is the final stage where cells die, acidosis worsens, and even fluids or vasopressors cannot recover perfusion. Our job as nurses is to identify it in the earliest possible phase, before the spiral begins. Let us apply this to a complex scenario. Imagine a trauma patient arrives after a motor vehicle crash. He is pale, restless, tachycardic at 140 beats per minute, and breathing 32 per minute. His blood pressure is 100/60, which may look okay, but the pulse pressure is dangerously narrow. Capillary refill is sluggish. He keeps asking for water. As a nurse, you must not be fooled by a borderline pressure. The patient is in compensated hypovolemic shock, and waiting for hypotension means waiting too long. Your immediate actions: activate massive transfusion protocol, establish 2 large bore IVs or a rapid infuser, draw labs including CBC, lactate, type, and cross, and prepare for balanced resuscitation with packed red cells, plasma, and platelets. Insert a Foley to track urine output, a critical perfusion marker. Administer warm fluids, maintain airway, apply high-flow oxygen, and continuously reassess mental status. In the early stages, you do not want vasopressors. They worsen tissue perfusion if given before adequate volume. Let us consider another complex scenario: a patient with pancreatitis who appears stable in the morning but becomes shaky and anxious by midday. She is tachycardic, complaining of abdominal pain, and her urine output drops from 40 milliliters an hour to 10. Her blood pressure remains 110/70, tempting you to think everything is stable. But this patient is quietly leaking liters of fluid into the retroperitoneum. She is entering third spacing hypovolemic shock, where no external bleeding is seen, yet the intravascular space is empty. The nurse who catches declining urine output and rising heart rate saves her life. Interventions in non-hemorrhagic hypovolemia include isotonic crystalloid resuscitation, such as normal saline or lactated ringers, correction of electrolytes, strict monitoring of intake and output, and treatment of the underlying cause, whether vomiting, burns, or metabolic derangements. Frequent reassessment is non-negotiable. Check perfusion, urine output, mental status, skin temperature, lactate, and if needed, point-of-care ultrasound to assess IVC collapse and cardiac filling. Let us elevate the scenario further. Imagine a patient with severe GI bleeding. He becomes diaphoretic, hypotensive, and cold. His lactate is 4. His hemoglobin, initially 12, is now 7. The provider orders vasopressors. As the nurse, your first role is advocacy. Vasopressors before volume will clamp the vasculature, worsening ischemia. You must clarify: do you want to initiate blood products first? This is the essence of clinical judgment, ensuring perfusion is restored from the inside, not artificially elevated by squeezing the vessels. Nursing priorities include maintaining airway and oxygenation, establishing IV access, initiating fluid and blood resuscitation, preventing hypothermia, inserting a Foley, applying continuous cardiac monitoring, trending lactate, and anticipating progression to respiratory failure or the need for central access.